Hello and welcome back, ladies and gentlemen. For our last session for today's event, to chair the last session on vasculitis, it's my privilege to welcome Professor Kavinda Dayasiri, Professor in Pediatrics, University of California. Over to you, sir.
Thank you, Bhatia. So welcome to the next session after the tea break. This is going to be on Kawasaki disease and childhood vasculitis, which is a critical and evolving area that bridges the pediatric and rheumatology care. Over the next 1.5 to 2 hours, we will delve into the complexities of childhood vasculitis. And it's my pleasure to introduce our esteemed speaker for this session, Professor Suma Balan. Professor Suma Balan is a distinguished pediatric rheumatologist and the head of the Pediatrics of Rheumatology and Clinical Immunology at the Amrita Institute of Medical Sciences, Kochi. She's also a professor in the Department of Rheumatology in the School of Medicine in Kochi. She began her journey in pediatrics at the Jawaharlal Nehru Institute of Postgraduate Medical Education and Research in India, followed by rigorous training in tertiary pediatric rheumatology in Nottingham, UK. And her key areas of interest include childhood vasculitis, juvenile idiopathic arthritis, SLE, and regional pain syndromes in children. She's a prominent member of India's pediatric rheumatology faculty and has presented and published extensively at international conferences in pediatric rheumatology. And following the presentation, we'll have a brief Q&A session as well, where you're welcome to share your thoughts and ask a few questions. So let's now welcome Professor Suma Balan to deliver her talk. Over to you.
Thank you very much for that kind introduction. There are two things that connect me and Colombo. One is the home state. I come from Cochin. Mahila Jayawardena was the captain of our Kochi Tuskers, which was a short-lived IPL team. Okay, and he's one of my favorite cricketers. The second thing is very current. This cyclone that you all have sent to India is raining and dropping landfall in the little town where I grew up and did my medical school and all my education in, Pondicherry. So we move on from here. So Pondicherry has taken the brunt for me to have a nice time in Colombo. Thank you. So what are the vasculitic illnesses? So they are basically inflammation of blood vessels. That's what vasculitis means. And there is a whole constellation of diagnoses. Some of them are common, some of them are rare, very rare. And what is common is many of these have multi-system involvement. And when we say vascular wall inflammation, it leads to the wall getting thickened, then stenosed and occlusion and ischemia, and that's the cause of all the clinical problems we see in these patients. As rheumatologists, if we are asked to have one skill, it's called pattern recognition. And that's what we do. Everything we see is pattern. So you see the many cases that Suleiman put up this morning is all patterns, and we pick up on patterns. That's been the focus throughout the last 2 days, if you see. So we see things and then we see patterns in them, and then we decide whether we are to be involved in this pattern or not. Okay? So overall, they say an overall incidence of vasculitis in children is 50 cases per 100,000 children per year. I don't know, I mean, these figures come from various international Western publications, and the problem, we don't really know numbers because we don't have incidence rates in India for KD or HSP. We are giving approximate numbers. What I see is, so Japan reports something like 250 KD per 100,000 children. In India, what has been roughly drubbed about is around 20-25, but we don't really know. We've never really collected a registry. So I suspect it is probably higher than that. And there is a lot of debate between Dr. Sujit Singh's center in Chandigarh does a lot of work with KD. And they will argue that KD is the most common pediatric vasculitis that they see, and we will argue that IgA vasculitis is probably the most common pediatric vasculitis we see, but we see enough of both of these, and many of the others are significantly rarer. Now, Takayasu disease again is something that if you look at the Caucasian world, it is not very common. It predominantly presents in the Asian world. Again, Japan, Korea, India, Sri Lanka probably. We see a lot of Takayasu. When I say a lot, it's not as much as KD and IgA vasculitis, but we see enough of Takayasu to keep us regularly refreshed with it. Okay, so the incidences that are there out in the public may not necessarily represent the reality. And when we talk about vasculitis, traditionally we said primary and secondary. I would like to add a third dimension, monogenic. So there are young children who present with certain vasculitic patterns could have monogenic causes of vasculitis, like sting-associated vasculopathy of infancy, DADA2, insufficiency of A20, which can look like monogenic Behçet, etc. And then you have the primary systemic vasculitis, and then you have secondary. Secondary vasculitis can be due to infections, due to drugs, due to malignancies, mycoplasma, common. Right now we have a huge outbreak of mycoplasma in India, and we're seeing so many patients coming with, so basically all the extra pulmonary manifestations of mycoplasma are immune mediated and vasculitic. And that's where we do have a major role. They come with funny thrombosis here and there. They come with autoimmune complications, because this bug is a fantastic molecular mimicker. Okay. Then drugs. One of the notorious things is cocaine laced with levamisole to make cocaine cheaper, and they come with all sorts of funny vasculitis as a result. Now, when we look further at vasculitis, we wonder, what are we dealing? What type? So you have the large vessel, the medium vessel, small vessel. I don't know, I love this fairy tale. Daddy is sitting on my chair, that one. So this is the latest classification we have from 2012, and that has divided the various vasculitic disorders in children according to the size of the vessel. Okay, so you have large vessel in children is largely Takayasu arthritis. Medium vessel is PAN and Kawasaki disease. PAN, you have systemic PAN and cutaneous PAN. And then you have small vessel vasculitis that are the immune complex mediated small vessel vasculitis and the ANCA associated small vessel vasculitis. And the immune complex, the most common is IgA vasculitis. We do see hypocomplementic urticarial vasculitis. Some of these can also go on to become monogenic lupus. And then you have the ANCA-associated small vessel vasculitis, where there are three. These all become very, very big terms now, because Wegener, Church Straws, all these guys were Nazis, and now we cannot anymore use their names. They've been withdrawn from those eponymous names, so we call them granulomatosis with polyangiitis, we call them microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis. These are thankfully quite rare, in children at least. And then you have this big group of variable vessel vasculitis or Behçet's disease, which can present at any size of vessel and across the entire vascular spectrum. So arteries, veins, and capillaries everywhere. Okay? So it's the same thing. When would you think about vasculitis? I think one of the primary sources of vasculitis patients to me are children with pyrexia of unknown origin and children with pyrexia of unknown origin with multi-system manifestations. Then you have these children with classic rashes, like IgA vasculitis would not enter a pyrexia of unknown origin paradigm, but most of the other vasculitis you pick up when you get references for this. And I think when you're lost with a pyrexia of unknown origin, you should call a pediatric rheumatologist. That's a very, very important part of the referral pathway. Then they have all these children with persistently raised inflammatory markers, not really quite well, but you can't put a handle on it. There is nothing outside on examination to tell you what's going on. And many of these children land up with a seal of tuberculosis and they don't respond to ATT. So what are the other clinical features you can look at? So the thing about large vessel involvement is that you have to go and touch this patient. You have to look for the pulses, look for the BP differences between different sites. Is there heart failure, cardiomyopathy? So you do not see things outside very clearly. You have to go and examine the patient for these findings. Medium vessel involvement, they will have symptoms pertaining to which vessel is involved. So if celiac acts as an SMA, abdominal pain; if it's the retinal artery, blindness or visual blurring; then claudication if the limb arteries are involved, chest pain, coronaries; then deep skin changes causing pain again; then hypertension, focal deficits, gangrene, orchitis, etc. So medium vessel disease, the patient will be communicating some key symptom to you. Small vessel involvement you can see. The skin will show you a flurry of findings to see, and quite often there can be other systemic features too. And these patients can have systemic features. Now, I hope there's no one in this room who doesn't know the diagnosis here. This diagnosis must be obvious, right? Yeah? Everyone's got it, IgA vasculitis, right? Now, there are some things, the rash tells you that. Why have I put, on the small of the back, you can see some swelling. He has some swelling in his dorsum of his hand. He has some swelling on his foot. What are these findings? This is not arthritis. What is it? It's actually cutaneous vasculitis that these patients develop, and it's very symptomatic, it's very painful, and it kind of, in positions, dependent positions it comes, and it becomes quite tense and painful. And this is part of the musculoskeletal manifestations, but it's not arthritis. Okay. Now we look at this child as a 3-year-old child. He presented to our pediatric surgeons with 5 days of abdominal pain and vomiting. There was no rash noted. He had severe pain. They were thinking of taking him for diagnostic laparoscopy, but they did imaging first. His blood tests were not particularly suggestive of anything. With the imaging, both the ultrasound and the CT showed jejunal and ileal segmental bowel thickening and edema with intermittent intussusception. What do you think? It's an acute presentation. What is the most important diagnosis you have to consider here? Come on, someone. So you're having bowel wall edema in multiple segments, and particularly small bowel being involved. This is bowel vasculitis. Okay? So thankfully they called us, and we went and turned over the patient and examined him nicely, and we found a few purpuric spots. Just a few. These purpuric spots of HSP, they actually become more activated when the patient is very active. So this is a patient who hasn't read the textbook. He got the abdominal pain first. And so he got his abdominal purpura first. And he got some skin purpura, but because he was not very active in moving around, it wasn't extensive. He did have purpuric lesions though. Okay? And that's the key factor, because now you have this patient doesn't need to go to theatre, you can treat him. My policy is to do a skin biopsy if there is any atypicality in the presentation. I will not do a skin biopsy if the diagnosis is very clear and the rashes look like the patient I showed you earlier. In this case, to convince the surgeons, we did do a skin biopsy and immediately gave him IV pulsed methylprednisolone, and he never made it to theatre. He did extremely well without needing to go to theatre. And this is what the CT looked like. Now, I told you that this child has intermittent intussusception. That is something you need to be very careful about. Sometimes, when they have intussusception with IgA vasculitis, they still probably do need to go to theatre and need to be managed surgically. But you can try a window of opportunity, give them the IV methylprednisolone, see if they settle. And if they settle, then they don't need it. So, many, diagnostic algorithms would tell you to involve the surgeon if there is intussusception. You must involve them, but that doesn't necessarily mean that they need to go, all of them immediately need to go to theatre. You have a window of opportunity. The child is clinically stable enough without any obvious evidence of intestinal infarction or ischemia. Okay? And we have had in the last few years a series of patients who have persistent bowel vasculitis despite giving them adequate doses of steroids. You bring down the steroids and they get symptomatic again. So what we found is that because we know that the bowel involvement in IgA vasculitis is actually a short term. It's not something that, it's not a persistent disease for, a very chronic disease in that sense. But if steroids are not enough for these patients, the best thing to do, we found, is giving them 1 dose of cyclophosphamide. 1 dose, and they settle down, and then they come off the treatments and they go back to being the regular on follow-up inoxaline purpura. So that was an article that was published from Turkey earlier, and recently some of our Indian colleagues also published a similar thing. So there are classification criteria, and you'll see how they have evolved from 1990 to 2010, where previously purpura was one of the criteria. Today purpura is a definite thing in the criteria, and then the other conditions are part of it. Biopsy is only one of the requirements in the criteria, so every patient does not need a biopsy. If you have atypical, then yes, but every patient does not need a biopsy. And if you're doing a biopsy, you have to do histopathology as well as immunofluorescence, because just leukocytoclastic vasculitis is very non-specific. It's when you have the immunofluorescence with the IgA deposition that you know you're dealing with IgA vasculitis. Okay. This is a boy I admitted this week and then ran away and came here. So he came with florid features. You can see my residents actually thought he had perichondritis, but actually he has such close, intensive purpuric lesions on his ears that it almost looks like perichondritis. And that's the other thing. This boy is around 7 years of age, and the younger children can have more of this cutaneous vasculitis component compared to the older children. Significantly, he also has epididymitis and epididymoorchitis again. So this is a patient you want to treat quite aggressively. IV methylprednisolone, giving oral won't cut when they have bowel vasculitis. It's not going to get absorbed. You have to give them IV and then move them on to oral. So what I say, so there are things about, the standard, bog standard HSP or IgA vasculitis is not at all difficult to diagnose. The thing is, there are other things that people don't actually think about with these patients. So they can have the vasculitic edema that I've explained. They can sometimes have paniculitic and bullous rashes. And the patients with the bullous rashes are often adolescents, and they have a higher rate of systemic involvement. And the bullous rash is one that quite often needs steroids. Epididymoorchitis can also lead to torsion, so it has to be treated aggressively. Any other systemic severe manifestation definitely needs aggressive management. If your patient with IgA vasculitis has ulcers, weight loss, significant constitutional symptoms, and significant inflammation, very high CRPs, etc., or pancytopenia, think this is probably not IgA vasculitis. This is a patient you should be biopsying and investigating more. So I have at least had 3 patients who turned out to be inflammatory bowel disease with vasculitic ulcer that looked like IgA vasculitis. They also had purpuric lesions, and the other features was what guided us. Then I've had lupus picked up, etc. Now I've just said this, and I'm going to contradict myself, because we had this 14-year-old boy who had a 3-week-long illness with a purpuric rash that went on to getting ulcerated with extremity edema, puffy eyes, oliguria, hypertension. He started having renal function deterioration and abdominal pain. His blood workup was not particularly significant, except very mild inflammatory marker elevation with a creatinine of 1, which is high at his age. And he had significant active urinary sediment and proteinuria, hematuria, etc. He also had bowel vasculitis. Now, look at these pictures. You would think this boy has lupus if you looked at these pictures, or you would think of some other vasculitis. So obviously this is the kind of kid you have to biopsy. Okay? The skin biopsy, IgA vasculitis. The renal biopsy, IgA vasculitis, but very proliferative disease. So this is quite aggressive IgA vasculitis, multi-system, and he needed aggressive treatment. He was quite sick. So we gave him steroids and we gave him cyclophosphamide and then kept him on azathioprine maintenance, and he was gone to a complete remission. He's now off all medications. This was several years back. So this patient taught me that sometimes you can get ulcerating lesions in IgA vasculitis, though that is not the norm. So what happens when you see a patient with IgA vasculitis? The most important thing is educating the parents. This is such a dramatic disease. There's so many skin findings. The parents get so scared. They get worried about all the things on the outside, whereas as a physician, you're worried only about what's going on inside. You're least worried about what's happening outside. There is a risk of recurrence. About 30% of these patients will have recurrent disease, and the parents need to be prepared for that. Okay? I would use only NSAIDs for the musculoskeletal and the cutaneous vasculitis aspect. I would use steroids only for bullous or very ulcerative rash, but let me tell you, most of these patients will have other systemic features that make you want to give them steroids anyway. And it's usually adolescents. See, 90% of IgA vasculitis presents under the age of 19. So pediatricians and pediatric rheumatologists are going to be seeing the largest number of these patients. The adult world, the IgA vasculitis is a different disease. It has much more systemic involvement, particularly renal, and it is much more difficult in a sense. Whereas the outcomes, the prognosis in children is very, very good in the very large, to a very large extent. So the way we need to manage them is different. You don't need to be giving steroids for the skin disease at all in children, unless there are very, very specific reasons. And the actual involvement of systemic, like bowel vasculitis, is a short-term treatment. The renal disease, the active, nephritis that leads to CKD is a very small portion of these patients. And they present in two ways. One is like the previous boy who presented with an overt glomerulonephritis. Then you have the small group of patients, very small, 1.5 to 2%, who will evolve as silent nephritis. When all the external manifestations are gone, the kidney continues to have proteinuria and slowly starts evolving as CKD. And this is why the biggest advice is to monitor these patients after the HSP. You get them to come back to you regularly, look at the urine routine, look at the blood pressure. By 6 months, if they have no proteinuria or what they had is completely resolved, then you can rest that this patient is unlikely to have long-term renal disease secondary to the IgA vasculitis. If you miss them, they will then next turn up with you when the GFR is dropped below 30. That's when they get symptomatic. So as I said, the role of steroids is when you have gut vasculitis, not abdominal pain. This is something I hear very often. This patient has abdominal pain, shall we give steroids? No. You please image the patient, find out what is the cause of the abdominal pain. If they have bowel vasculitis, they could have urethritis, they could have many other reasons. You find out the cause and then treat it. Okay? And it's simple imaging, that's all you need to do. And epidermolysis, of course, needs, then if you have any serious systemic involvement, you need steroids. If you have severe renal involvement, you need more than steroids. And now what about, a lot of dermatologists actually have this tendency to keep giving steroids because they have skin lesions. So there have been, this is one meta-analysis I'm quoting, but there have been several others which have said that there's absolutely no benefit, no change in outcome with using early steroids in these patients. And considering all the side effects, we definitely not want to do that. And look at this child. He came to us on the left-hand side. He came to us a year on steroids just because he gets recurrent HSP rashes given by a dermatologist. He was hypertensive as well. We weaned and stopped the steroids. Nice, smart young man, and his hypertension's gone. We could stop his antihypertensives. So this is a related condition. It's a young baby who's had a febrile illness, and sometime a few days after that, this developed this acute purpuric rash. The parents were so alarmed, they came to casualty at 3 a.m. with this child. And he had some musculoskeletal features with capillary cutaneous vasculitis and arthritis, and had mild urinary sediment. This, in the active phase, if you have asymptomatic mild urinary sediment, you don't need to do anything about it. You need to follow it up though. And he responded very well to just NSAIDs. And this is the extent. You can see the kind of lesions that he had. This is acute hemorrhagic edema of infancy, a related condition. These patients are actually quite well. They're non-toxic, but the rash is so dramatic that parents get very, very worried. the biopsy changes are quite, they have subtle differences. So you have some fibrinoid necrosis, you often have IF negativity in these patients, and the prognosis is even better than for IgA vasculitis. So we'll move on now to the next disease that's pretty common, and I hope all the pediatricians here are sitting up in attention. So this disease should not be a difficult one when all these findings are there for a pediatrician to diagnose. So a little child under the age of 5 with very high grade fever and who develops all these various features, you can see the non-purulent conjunctivitis, you can see the BCG scar activation, the periungual peeling that happens later, the red lips and the strawberry tongue, the unilateral lymphadenopathy, the maculopapular rash. There can be different kinds of rashes, and of course the cutaneous vasculitis, which is very painful, and a very, very irritable child. Okay, we must not miss this diagnosis. The caveats that happen, all this doesn't come together. So the little baby will have a rash the first day, it goes away, then develops red lips and tongue, then develops the lymphadenopathy another day. In India, people go to pediatricians in private practice, so one person will see one finding, other person will see another finding, and the parents will not be happy because the fever is not coming down. They keep changing doctors, they see different aspects, and this delays the diagnosis for the child. So take good history, find out all the things. It's again very, very much a clinical diagnosis. But it's a clinical diagnosis which we don't make in time, has severe consequences. 25% of children with Kawasaki disease can develop coronary artery aneurysms, which can cause sudden death. And it's also important today, we've moved on a long time. We've actually understood this disease and the pathogenesis much more. What we have learned is that we are not waiting to find out that this child has IVIG resistance. We are stratifying the patient at diagnosis using the clinical pictures to find out which child is likely to have IVIG resistance and which child is at high risk for aneurysms, and treat them differently from the child who doesn't have those features. Okay? So Tomisaku Kawasaki published this clinical criteria in 1967. Isn't it wonderful that they haven't changed over all these years, nearly 60 years? And these clinical criteria, the important thing is that different things predominate at different times. But what is most important is that in the early stage, you will see the much more sicker, unwell kid. The aneurysms start developing at the end of the first week. And that's one of the reasons why we want to optimize the treatment before day 10, so that we can reduce the degree of damage the child is going to have. The desquamation often starts around the same time that the aneurysms are developing in the patient, or after, in fact. And they have these Bose-Line specific nail changes which happens in the convalescent period. So the focus of Kawasaki should be to make our diagnosis in this period, because once you go to this period, the aneurysms are going to progress, and there's very little you can do to really arrest their progress. Okay? So the other big dilemma we face is infants, particularly infants or children who have some features but not enough. Okay, so you can't make a hardcore diagnosis of KD, but you are suspecting. So an infant, particularly, even more important, because in infancy, the risk of coronary arteries aneurysms is 50%. Okay, so you have to take these children much more seriously. So when you have a febrile infant, particularly an irritable febrile infant with raised inflammatory markers, one of your differentials should always be KD. You should be getting your pediatric cardiologist to echo these patients and follow up the coronaries. If you're seeing coronary changes in these patients, even if they don't have adequate criteria to make a clinical diagnosis of KD, you should treat them like KD. And we'll come back in a minute to see what it means to treat them like KD. So there are also many other systems that you can get other than the classical features. You can get involvement in so many other systems. So the kidney and the ureter, etc. You can get the sterile pyuria. You can get respiratory changes. You can get anterior uveitis. You can get aseptic meningitis. That's why they're so irritable. And you can get various abdominal symptoms, gallbladder hydrops, jaundice, etc., coming to these patients. Any guesses what this finding is? This is a young infant we had with KD with this finding and what it means if you see it. So this is a facial nerve palsy. It's part of the aseptic meningitis process. It indicates a very aggressive vasculitic process and a very, very high risk for coronary aneurysms. Okay. So as I said, we've come a long way with our journey in KD. So the first description was in 1967. People started treating this condition gently, initially aspirin, because those were the drugs that were available then. Immunoglobulin was first used in 1983, and the trial was conducted in 1991 and established that we have the standard dose of 2 grams per kilo that is really making a difference to reducing the risk of coronary aneurysms from 25% to less than 5%. But what happened is around this time, steroids got a bad name. They got a bad name because they were used without associated IVIG. So people were giving steroids to a little more sicker patients, aspirin to a little less sicker patients, and many of those patients on steroids died. They thought it's a paradoxical reaction of steroids, and steroids are a no-no in KD. But what we found out subsequently is that those would have been the sicker patients. They actually needed more aggressive therapy, and that's why they died. Okay, so the Japanese, they devised a number of clinical risk scores. There are a whole lot of Japanese names, Kobayashi, Egami, etc. So many of them are there. And they looked at simple clinical parameters, so the age, the sex, the ALT, the presence of coronary aneurysms at onset, the level of the platelet count, the level of sodium, etc., all of which basically give you a picture of more aggressive vasculitic condition, and they created clinical scores. It worked very well in Japan. With these clinical scores, they were able to pick up the high-risk patients who were very likely to have IVIG resistance, and they started the RACE trial, which was concomitant steroids along with IVIG in the high-risk infants. This trial was so wildly successful. The patients with the high-risk KD who got steroids along with IVIG had a significant reduction in coronary aneurysms compared to the ones who just got high-dose aspirin and IVIG. And that changed their approach completely. Subsequently, there was a lot of work done. As we know the pathology more, we know that the anti-TNF pathways are involved, we know that the calcineurin pathway is involved, we know that IL-1 is also an important cytokine in these patients. So many trials were done regarding all these patients, and all this has gone on to change the current treatment paradigms for these patients. And so today, before I show you this, I'm going to show you this one. This came out hardly 2 weeks back, the latest American Heart Association guidelines in the management of KD. This is largely a pediatric cardiology-led guideline development. And if you ask my honest opinion, I respect pediatric cardiologists greatly. I work extremely well with the team that we have. And however, my team are the first people to admit that they don't understand the management of systemic vasculitis or the immunosuppression. They understand the process of following the coronaries extremely well. And they clearly are the guys you want in the chronic management. But for the acute management of KD, it should be guided with pediatric rheumatology, because you need to control that inflammation, you need to control that vasculitic process as aggressively as you can. So there is the statement here, which I put under the pink line, which says first line treatment, IVIG and aspirin. We are going to respond as a Pediatric Rheumatology Society India to say that that first line treatment word needs to come out, because that implies that every patient gets high-dose IVIG and aspirin first. That's not true. The high-risk patients need IVIG for sure, along with other modalities, not high-dose aspirin. High-dose aspirin does zilch in reducing the risk of coronary aneurysms. It's purely an antipyretic, and it does absolutely nothing towards a reduction of aneurysms. So that is a thought process that we need to think again. And with that, I'll come back to the previous slide. So my colleagues from Chandigarh actually wrote up this elegant thing, which is now the kind of thought process that goes across multiple Kawasaki disease workers across the country in different ways. So if you have a child, an infant or adolescent, particularly male sex, with very long duration of fever at the point of diagnosis, even very early diagnosis, if you manage to diagnose on day 3, day 4, that means you have a more aggressive vasculitic process. If you already have a demonstrated IVIG resistance, if you already have coronary artery involvement at baseline. So all this tells you you're dealing with a child who's much more likely to develop giant aneurysms. The entire objective of treating KD is to prevent giant aneurysms. It's a horrible life for the child and the parents once they develop giant aneurysms. And then if they have macrophage activation or Kawasaki disease shock syndrome, that is also significantly associated with the formation of giant aneurysms. So for these patients, we would do primary intensification of treatment. What they tend to do in Chandigarh, they give infliximab immediately followed by IVIG and then steroids to the patient, plus or minus cyclosporin if the patient already has giant aneurysms at presentation. What many people would do is give these high-risk patients steroids along with IVIG and add in infliximab subsequently if the vasculitis doesn't settle. What we have learned with time, the drugs that definitely reduce the risk of coronary aneurysms, IVIG, steroids. Infliximab controls the vasculitic process very well and indirectly, therefore, can reduce the risk of inflammation in the coronary vessels and can reduce the risk of, but it's indirect. The direct things have not yet been analyzed, and that's probably because the studies that used infliximab were set up in such a way that that particular primary endpoint could not be realized. Cyclosporin is another drug that has been shown to be significant with reducing the coronary artery aneurysm risk. And of course, anakinra, there's work in progress with anakinra and other things. But steroids, for sure. So if you have high-risk patients, steroids with IVIG would be the way to go. And then the only thing you have to remember is if you're giving them infliximab after IVIG, you need to give them a higher dose, 10 milligram per kilo, rather than the 5 to 6 milligram per kilo you give pre, because once you give them IVIG, their uptake, the blood availability, the pharmacokinetics of the infliximab is slightly altered. The reason why the PGI team want to give infliximab first is to avoid that thing and then they follow. But that is a personal practice change. I tend to go for steroids with IVIG and add in infliximab. But if my patient has come with giant aneurysm, we often add everything. We go for multimodal therapy straight away. And so I hope I have changed your perspective in the way you look at Kawasaki disease, because I think it's time we spoke of more than what we learned 30 years ago. At the recent Pediatric Cardiology Society of India, we presented this poster which looked at, ours is a tertiary hospital. We have a huge tertiary bias. We are going to see the worst patients for sure. So we are going to see patients, many of our KD patients are referred from outside. So they've already had some treatment and then they come to us. They come to us not just in the acute phase, they come in the chronic phase because of complications. So there's no doubt we're going to see more giant aneurysms than any other standard first-line responder hospital. No doubt about that. Despite which, we have a very, very high number of giant aneurysms. And we went back and looked and we found that the most important factor here was the delay in intensification of treatment for these patients. And that is the one factor that has made these patients, so all these were high-risk patients, they had enough features in their initial presentation show that they were high risk, but they were just treated with high-dose aspirin and IVIG. Sometimes they've given a second dose of IVIG. Other treatments were not considered for a very long time. Personally, I don't understand. I understand why people started using second dose of IVIG, but with all the newer developments we have, I really don't see why that should be considered treatment when you have other agents which can address the condition from different pathways, which can be more effective. But anyway, that's what we saw. And really, when you have a child with giant aneurysms, that means enoxaparin, BD, 2 daily injections for a very long time. Do you really want little children getting that for a very long time? Oral warfarin is horrible to use at this age. You can never get the right dosage, the right blood levels in them. And I even had a child who because they protested significantly, the pediatric cardiologist gave them oral warfarin. He came back with multiple intramuscular bleeds, hemoglobin of 4. We had to transfuse him. It's a nightmare. So enoxaparin is the safest, but it means 2 daily injections, which is horrible for these children. Additionally, what about the risks they carry? In our group, we had one patient died. One patient had a CABG at the age of 6.5 years. He had 3 MIs prior to that. 3 patients underwent CTPA. 3 patients underwent MIBG scans because of recurrent MIs. They did not need a CABG. It settled down with conservative treatment. But there's a huge consequences. So we really need to approach Kawasaki disease differently. We'll move on now from both these common vasculitis to lesser known vasculitis. Here's a 13-year-old girl. She has multiple painful paniculitic lesions over the last 2 to 3 months with some elevation of inflammatory markers. And naturally, we do a skin biopsy because that's what you need to do for these patients. And when you have paniculitic lesions, you need to go for a deep skin biopsy, which includes a subcutaneous fat, because that's where the inflammation will be, and you'll miss it if you don't do that. So dermatologists sometimes will tell you, send this patient to the pediatric surgeon and get a nice incisional deep biopsy rather than the simple punch biopsy, which may not pick it up. And the biopsy showed necrotizing paniculitis with medium-sized artery involvement and a neutrophilic infiltrate. And with all the things we had, this is cutaneous pan. The child had no evidence of systemic involvement. Now, is cutaneous pan always a mild disease? No, we have children. Please note the first picture. This sign you can see here, something called livido reticularis. Okay? It's something you mustn't miss because it can be seen in other conditions too. You can see it in Sjogren's patients, you can see it in APS, and you can see it in PAN, okay? You can also see it in the DADA 2 patients. So it's something you mustn't miss. When you see this sign, you need to be thinking about these possibilities in your mind. And these are the lesions she had. But this is a patient who went in for gangrene. So cutaneous pan can be a very severe disease requiring very aggressive immunosuppression. So you have to treat each patient as they present. So you can't give the one-size-fits-all treatment to everyone. So when the diagnosis is basically, there are no diagnostic criteria for cutaneous pan. You're looking at the CPAN, the childhood systemic pan criteria, and superimposing that to the cutaneous variety. So they have skin involvement, they have absence of visceral involvement, they have a biopsy showing you the medium-sized vasculitis, and you need to also look for exclusion criteria like presence of other identified vasculitis ongoing in this patient will take away the diagnosis. Okay. Now, this is a very interesting child who came to me, and I followed up for many years. She presented as cutaneous pan, 11-year-old girl. She had fever, not very high grade, but she had fever at the first presentation with painful skin nodules over the lower limbs. She had edema of the feet, mild swelling of both ankles, so there was some arthritis, and a vasculitic ulcer over the left foot. And, she had all features of inflammation. She had a biopsy that showed medium vessel vasculitis, and the IF was negative. So we thought she fitted cutaneous pan. We had to treat her fairly aggressively. Steroids, methotrexate wasn't enough, so we had to give her MMF and some colchicine as well, and she improved very nicely. And I started weaning her medications, thinking maybe I don't even need to transition this child. And just when I was doing that, and she moved from school to college, she came in with acute onset giddiness and had cerebellar ataxia, and an MRI showed an acute infarct of the left pons. Now, what does this mean to many of you? I mean, this was a kind of, for me, a bulb lit up in my head immediately, and I did a test which confirmed the diagnosis. But you have a child who you thought had cutaneous pan, she was niggling inflammation, but she settled down, she's doing well, and then she comes back with a deep infarct, okay? This is one of the situations where you have to think of monogenic pan, and we did functional adenosine deaminase 2 levels. It's done in Gangaram Hospital in Delhi. You can probably also send it to them. It's not very expensive. ADA2 levels were 0. We confirmed the genetic mutation, and what she has is deficiency of adenosine deaminase 2, which is an autoinflammatory syndrome. It has many phenotypes, but this is one of the phenotypes. So recently, DADA2 was first described in 2012, and ever since then, many of us have gone back to looking at many of our cutaneous PAN patients and doing ADA2 levels in them to see whether they could be actually innocently DADA2, which presented like cutaneous PAN. And I must say, in my entire series, this is the only one. However, it was a life-changing experience for me. And she's doing extremely well on anti-TNF. The beauty about these vasculitic forms of DADA2 is that they respond beautifully to anti-TNF therapy. If you have the immunodeficiency version with significant bone marrow changes, etc., those patients need stem cell transplant. How do you treat cutaneous PAN as a whole? You have to look at each patient and look at the extent and severity of involvement. I have patients with such mild disease, all they need is initial naproxen and colchicine to maintain the inflammation. And I have the other end of patients who have required steroids, significant immunosuppression, and biologicals. So it is a spectrum, and you have to treat according to the patient. Let me tell you, it's the pediatric rheumatologist who will see more cutaneous PAN. It is in adult rheumatology, systemic PAN is more common than cutaneous PAN. And in pediatric rheumatology, cutaneous PAN is more common than systemic PAN. And sometimes cutaneous PAN, very infrequently, can evolve to systemic PAN. So these are things to keep in mind. This is another boy. He was a teenage adolescent boy who presented with large panniculitic lesions. And again, this brawny edema, painful edema, is also something we constantly see in these patients. It's part of the inflammatory vasculitis that is there, biopsy proven. And he is doing well. He also required steroids and then mycophenolate, and he's doing well on that. This is another child, a 9-year-old girl with fever going on since 6 weeks. She has some arthralgia, some morning stiffness, some thigh and calf pain, difficulty in standing up and walking, so muscle involvement, arthralgia, fever, not really well, this girl. And she's been seen by a number of people, tests done at different times. You can see the progression. She's having anemia, significant neutrophilic leukocytosis, thrombocytosis, very high inflammatory markers. This is an inflammatory pattern of counts. Okay, she's dealing with a chronic inflammatory disorder. And what happens to her? Then she gets hospitalized, and she has very hectic spikes of fever. And she has mildly elevated blood pressures, and then she develops nasal regurgitation of fluids and the nasal twang, and an NCV was done which is suggestive of neuropathy. At this point, rheumatology is called in, and this is what we see. We have a child with chronic disease, systemic inflammation, constitutional features, musculoskeletal features, GI involvement, and peripheral nervous system involvement, so multi-system disease. We asked for a CT angiography, which showed some findings that I will show you. And then she also developed some nodules which were biopsied. Okay? And we started her on steroids. She got better. The nodules were biopsied, and that nodule showed, medium vessel vasculitis. An ultrasound Doppler was done at the same limb, and then she started developing darkening of the tips of the upper extremity with occlusion of the distal radial and ulnar vessels. Is this story picking up? And this is the CT angiogram, and you can see the classic beaded appearance of the renal arteries, the SMA, etc., which is suggestive of medium vessel vasculitis, systemic polyarthritis nodosa. And this is thankfully not a common condition. I don't know, in the state where I come from, I don't see many of this. There are other places in India. I have realized that many vasculitides do have certain pockets where there's more of them seen. Similarly, I've also realized that diseases can present slightly differently in different places, like Kawasaki disease. There's a huge amount of Kawasaki shock syndrome in certain parts of India, which is something we rarely see. So it's important, especially in a large country like us, it's very important for us to share notes. So this is how you make a diagnosis. This child is, you first identify you're dealing with an inflammatory disease, and then vasculitis becomes one of your differential diagnoses, and then you start working up. So what are the findings this child has? What are the tests you need to do? So you're seeing a lot of things outside. There were nodules you could biopsy, and you should be doing, there's some mild hypertension, that is, you should be doing a CT arteriogram for these patients. Okay, that's how you make the diagnosis. And you have, again, criteria for diagnosis, which are very helpful, because if you see this child actually does fit many of these criteria. And usually the monogenic pan, I don't see aneurysms in them, but I'm sure there will be some patients who have it. Then we have all these interesting patients. We have a lot of these myriad ones in my state, and I think you will do as well in Sri Lanka. So this 10-year-old girl with fever, severe headache and blurred vision for 15 days was being managed as raised intracranial tension outside, and she was on acetazolamide, not improving, came to us, and we noticed, she had, wherever she was pricked, she had LP, she had a lot of blood tests done, she had cannulas, everywhere she's developing nodular swellings with this kind of vasculitic lesions that is there. And then we did, so the first thing we did was biopsy this. She has very high inflammatory markers, she's febrile, she has so many features to see, and we asked our ophthalmologist to look at her again. And this is what the ophthalmologist saw. She had severe bilateral combined vasculitis, so venous and arterial, with all quadrant thickening. The skin biopsy told us it was a medium vessel vasculitis. What we were actually seeing was induced pathergy. And this child clinically would be a form fruste of Bechet, but she would not fit criteria adequately. She's never had an oral ulcer in her life. She was not HLA-B51 positive. But we treated her aggressively like a systemic vasculitis, when we saved her vision, and we got her, she's now off immunosuppression and doing really, really well. So these are very, very myriad. So you can have patients who present very typically, patients who present very atypically. So you can have children presenting with this kind of oral ulcers and this horrendous kind of skin lesions, very, very vasculitic skin lesions. Biopsy them and you'll get your answer. You can, boy with scrotal ulcer, girl with vaginal, with vulval ulcers, and genital ulcers are very, very depressing for these children, because they heal with scarring, they are very uncomfortable, and this is something that should automatically make you think of this condition. And there are 3 diagnostic criteria for Bechet. 2 of them are basically from the adult rheumatology, more towards adult criteria, and then you have the pediatric Bechet criteria that came out in 2015. The one little bias is that a lot of Bechet criteria have come from areas like Turkey, etc., where they have a very, very, very high preponderance of patients with Bechet. So they see patients with very many features of the disease. And I think along the Silk Route, we've all fallen along the Silk Route somewhere, in Sri Lanka, in Kerala, everywhere. And we possibly don't see the exact, all those many criteria at one time in a child. So for us to make a definitive diagnosis can be quite hard. GI, just 2 weeks ago, I had a girl from the Maldives who had oral ulcers, genital ulcers, and an inflammatory bowel disease that looked like the Bechet form fruste, because there were no granulomas to call it Crohn's. But again, even she wouldn't fit criteria, because GI is not given any points here. Okay, so criteria are useful, criteria are necessary for you to understand the disease, for you to help, but you must not use only criteria to decide on treatment. Okay, that's where maybe experience also factors in, and that is an important take home, because the majority, we actually looked at several 5 years back, we looked at a range of patients whom we thought had Bechet. We looked at the adult criteria and the pediatric criteria, and surprisingly we found that the adult criteria actually suits us better than the pediatric criteria. It's something I'm very sad to accept, but then that is true. Superficial thrombophlebitis recurring, that is another big red flag for considering Bechet. And it's important to know these patients, because sometimes they can have really serious conditions. This was another very interesting boy. He presented to us with Well, this history was recurrent fever, oral ulcers, paniculitic erythromaneurism kind of lesions, scleritis, and also polychondritis. You can see his ears are inflamed. But he was continuously on steroids as well, on top of which he gets sort of recurrent flare. So it's more of a continuous disease rather than just a recurrent disease. He has high inflammatory markers, and the skin biopsy again showed a medium vessel vasculitis. Bechet is a pan vasculitis, so it can show small, medium, large, anything you can see. But this is called magic syndrome, which is just a syndrome. It's not a particular diagnosis on its own. It's not an etiological diagnosis. And that is mouth and genital ulcers with inflamed cartilage. And in his case, it was Bechet with a magic syndrome. He responded very well to treatment. This is a horrendous case, whom I never saw this child, but I was involved in all the case conferences dealing with her treatment. So a 9-year-old girl who presented quite late from a very poor rural area to one of the government hospitals in Kerala. And she was brought there because she was having recurrent large hemoptysis. And when they took a history, she has oral ulcers, paniculitic lesions, and the hemoptysis started about 2 years after she would have skin, oral, and even genital ulcers at that point, and the diagnosis was never considered. And when she underwent CTPA, what was found was she had an obliterated stenosed right pulmonary artery. The left pulmonary artery had this massive aneurysm with a massive intramural thrombus. And there's no doubt this is Bechet disease. And this is probably one of the most dreaded complications, and usually seen in young adolescent males actually, or young adult males. In this case, it was a girl before her 10th birthday. And this is associated with quite a high mortality. The aneurysms of Bechet are presumed to be inflammatory, and the treatment is actually immunosuppression and treating with anti-inflammatories. Particularly in pulmonary thrombi, they do not advise using anticoagulants because you can actually worsen the process and cause a fatal hemoptysis by doing that. It's one of the slight exceptions in clinical medicine that you have. We supported this child best we could. They gave her steroids, they gave her infliximab, they gave her cyclophosphamide. She stabilized for a few months, but they could not continue the treatment. And I heard finally she died in her own native place. So that is a caution that we have to remember, that this disease can be really bad. And this one, they're rare to me. I don't have many of these patients, and I'm thankful I don't. It's a 12-year-old girl. For 1 or 2 months, she's symptomatic with fever, a purpuric rash that comes and goes, increasing cough, hemoptysis, weight loss, and scleritis. You can see the scleritis. So it's chronic. There is an inflammatory, there's a multi-system involvement. Okay? So one of your thoughts, I'm not saying all your thoughts, one of your thoughts has to be a systemic vasculitis. Her blood counts are suggestive of inflammation. Her serum creatinine is slightly elevated for her age, and she has significant findings for a glomerulonephritis on her urine examination. So one more system is involved. And because of the cough hemoptysis, she gets imaged, and you're seeing patchy areas of ground glass and nodular opacity. So here is the clear case of a pulmonary renal syndrome. When you have a pulmonary renal syndrome in a chronic sense, you have mainly 3 conditions to think of: lupus, ANCA vasculitis, that is 2 different MPA or GPA or EGPA, etc. This has to be very strong in your contention, and you have to do the workup for them. And in this case, she was C-ANCA positive, anti-PR3 positive, and this is granulomatous polyangiitis. This is the C-ANCA, the neutrophil that is stained, is showing the cytoplasmic antibody. And perinuclear or P-ANCA would show the immunofluorescence taken up in the perinuclear area. Again, you have, these are helpful, these diagnostic criteria, but it's more helpful that you think, you put the patient into focus, you sit back, look at everything that is done and think, because it's quite common for these patients to be thought one infection after another, TB, try ATT, try this, try that, etc. Whereas the actual disease is something else. And this is a disease with a high degree of mortality if it is not diagnosed early and treated with the aggression required. And then large vessel vasculitis. It's very quiet, but it can be quite nasty. Considered to be quite rare, again, I think it differs across populations. I think the Asian population, we see a lot more large vessel vasculitis than the Caucasian populations do. And this is classified into different types depending on the degree of involvement. So you can just have the arch and the arteries coming from the arch. Then you can have the ascending aorta, the arch, as well as the thoracic portion of the descending aorta. You can have the entire descending aorta involved with its branches, or you can have only the abdominal part of the aorta. So this is, knowing the type is based on the angiographic pattern. Okay, you cannot do that clinically. It has to come from the angiographic pattern. What are the challenges to diagnosing Takayasu arthritis? Main challenge, we don't think about it. The best thing is if you can diagnose it in the pre-pulseless phase. And for that, you need to be aware that in your patient with PU, in your patient who has constant elevation of inflammatory markers but no real focus on examination, this could be a possibility and you need to image for it. Okay? You can have raised inflammatory markers which go on like that. There are disease activity indices. I'm proud to say that the Indian Takayasu arthritis score is now worldwide the most widely used disease activity score in Takayasu arthritis. And ESR, CRP are not enough actually to look at disease activity in these patients. We need better biomarkers and we don't have them yet. And also there are many aspects to treatment. You have the medical treatment and you have the interventions. So the interventionists and the surgeons are rushing to get in there, but we want to fob them off and tell them, no, not yet, you can't get in yet. And how long do you treat these patients? There are many, many questions which don't necessarily have definitive answers. But we have to think about this possibility. Only if you think you'll find the patients. Again, you have criteria, and the criteria starts with angiographic abnormalities. So without angiographic abnormalities, there is no diagnosis of Takayasu arthritis. So you have to think, you have to suspect, you have to do the necessary test, and then see whether they fit into the other clinical features. So look at these findings. Your patient is not going to come and say, I don't have a pulse. Right? They can come with symptoms of hypertension. They can come with symptoms of claudication, but you need to detect that. You need to go and examine them for it. So large vessel vasculitis is very silent in its presentation. We have to look for it. So here is an 11-year-old girl. She had a 1-month PUO, myriad aches and pains, loss of weight, fatigue, raised inflammatory markers, extensively evaluated for infection, which is negative. She had normal peripheral pulses. Her full-limb BP was normal. And so we thought of many things. Could this be IBD? Could this be a vasculitis? Could this be a malignancy? So the best shot test really here was thinking of doing a whole body PET MR. Okay? And that test actually gave us the answer. She had diffuse FDG avidity along the wall of the ascending aorta and the carotid arteries. So more like a type 2 kind of Takayasu arthritis, pre-pulseless. If we had waited, not picked up the diagnosis and kept her going, after 6 months she would have presented with either symptoms from carotid artery claudications or maybe a pulse gone somewhere, and then you would have picked up the diagnosis a bit better. But you can pick them up early if you suspect this diagnosis in children presenting with PO. And FDG PET MR or CT is certainly, considering the amount of cultures, the infectious investigations we do, the very costly antibiotics that are given to patients, this is a very valuable test that can help you if you know how to select your patients for it with regard to a wide range of conditions. So it's not just large vessel vasculitis, it can be malignancy, it can be other things that you can pick up based on either a PET CT or a PET MR. And we've been trying to do this for the last few years. We have 22 patients with FUO, and we have a 96% pickup rate of diagnosis. in these patients, which means very, very few of these scans were actually negative and completely normal. So this is something to think of earlier on when you have patients who are troubling you with inflammation, troubling you with fever. You don't have an answer. You know, rather than going on, guessing and doing various things, this is a test that can help you. This 9-year-old boy, this boy I saw 10 years back, ongoing low-grade fever, several months, paniculitic skin lesions, empirical ATT showed no improvement, and by the time they came to us, he had significant pain of his left arm. When we examined him, there was no left radial pulse, there was a BP difference between the two arms, and he had very high ESR and CRP. This is not difficult to diagnose, provided you examine this patient, you recognize that that is claudication. Okay, and not surprisingly, you can see his CT aortogram shows that his subclavian artery is involved, and he has, again, the arch and subclavian artery, etc. were involved. So, approach to pediatric vasculitis, first think of it. And you look for clues from all the tests that you do, the simple basic tests that you do for patients. Try to put your story together. Then you decide, will serology help? It's not helpful to do ANA on everybody. If you have a pretest probability of lupus, a very useful test to do. So if you see that girl with the pulmonary renal syndrome, her blood counts suggested to me that this is more likely to be an ANCA vasculitis than, but I wouldn't fault if you did an ANA and an ANCA in that patient. Whereas these other children with the pulseless and all, there's no need to do ANA, ANCA, etc. in those patients. It's not going to add any value. So for small vessel vasculitis, it is generally biopsies that help you, and serology can help you. For medium vessel vasculitis, if you have the clinical, if you have the skin lesions, if you have nerve involvement, you have significant muscle involvement, biopsies can help you. Otherwise, it is imaging. If you have large vessel vasculitis, your diagnosis is basically made on imaging. And that's the way you need to think when you think about these patients. So management-wise, there are current protocols that define the standard of care for many of these conditions, but early referral is advised because these conditions do have significant sequelae. So early referral so they can get the right diagnosis, they can get the right treatment is important. We don't treat only with steroids in the majority of vasculitis. We used associated immunosuppression. The right drug, the right protocols need to get in. Aggressive management of multisystem disease with a multidisciplinary care is important. And counseling the patient and the family about the disease, the natural history, what to expect, etc. are equally important. And we should not be in this situation. Doctors, why you no understand my disease? I'll stop here. Thank you.
Thank you very much, Professor Suma, for that illustrious and excellent presentation on childhood vasculitis. We can now take a few moments to ask a few questions if you have, or share your thoughts.
Thank you, Suma. That was very, very good summarizing the big topic, and you did very well. I think it's very helpful for our juniors. And for me, I think I bombarded Liz with questions, how to tail off Takayasu. I don't know, the world does not have an answer to that. Yeah.
There's no consensus there.
Yeah.
I think Takayasu is a chronic lifelong disease. So some important parts of treatment are, there are patients who are going to need, there are patients who present with coronary artery involvement. So that is a patient who's going to need intervention at the point of diagnosis. So you have to give them anti-inflammatory therapy up front. So because the moment you stent a patient without anti-inflammatory therapy on board, that stent is going to get blocked and the intervention is going to fail. So the diagnosis for intervention in Takayasu is when inflammation is controlled. That's when it works. So even renal artery stenting, and actually they advise renal artery balloon dilatation rather than stenting in Takayasu patients. But even then, doing the intervention is advised when the disease is quiescent. So if you have time to treat conservatively, give the anti-inflammatory therapy and keep blood pressure controlled on multiple antihypertensives, get the disease into quiescence, and then do your intervention. And of course, none of these patients we want to keep on steroids long term. So if you don't have good secondary immunosuppression thrown in, you will not be able to get them off steroids. For children, it makes a very big deal. I simply cannot accept a child being even on 5 milligram once a day steroids for their life long. That's not acceptable. And so we do try, that's why we get in immunosuppression. Children tolerate systemic immunosuppression much better than adults do. And even biologics have made a big way into Takayasu now. CMC Vellore has shown how trying to put out the fire very early. So they give a lot of patients, they start off with steroids, tocilizumab, and an immunosuppressive agent. And they find that they're able to taper and stop the tocilizumab within 6 to 9 months, maintain and reduce the steroids also considerably, and maintain them just on mycophenolate quite successfully. So it's about putting out the fire initially in patients who present with very active inflammatory disease. In the long term, can you ever stop I have stopped in a few patients because they're really, really quiescent, but it's not something you can guarantee for everybody. And there is no definite consensus here. You have to see your patient and assess and take it there.
Even the patients you manage to stop it, you really follow them up?
Absolutely, you follow them up, yes. And the problem is, when the disease is chronic, you cannot even depend on the inflammatory markers to tell you that the disease is flaring. It's a very poor representation of the inflammation that's going on inside. CRP, ESR are not adequate, but we don't have better biomarkers.
It's a nightmare. You make me more comfortable, a bit more comfortable.
Yeah, because we are all in the same pit, aren't we? Essentially, yes. Yes, please, yes. You can take the mic so everyone can hear your question.
Madam, in patients with Takayasu who are in need of any sort of intervention, when are you comfortable to refer them for an intervention? Like, how do you define remission? What drugs should they be on?
So, I think when we are talking about an intervention, we need to make sure that the inflammation is in control. That is the main thing. So, you look at, the signs of inflammation and the signs of disease activity can be a little difficult to tease out, because claudication can be a sign of both, for instance. But you need to probably be guided by many other factors, like you have renal artery stenosis and your patient, you've got down your ESR, CRP, many other things have come down, but the hypertension is still a big problem and you need to be doing an intervention for them. Now, I would personally prefer my steroid dose to be down. It all depends on how urgent the need is for the patient. You're on 4 antihypertensives and the blood pressure is still not good. You need to do an early intervention. You come down from 4 to 2 antihypertensives. You're doing okay. You can wait a bit longer to do the intervention. So it's a combined discussion. The other very important thing is when you get the surgeons in. So we have many patients, I didn't put those slides, where we actually have large aortic dilatations and all in these patients, and those kind of patients will need cardiothoracic surgery to help them out in the long term. It is overall, the story of interventions in Takayasu itself is there are two opinions here. So when there are definite clinical situations that require intervention, there's no doubt about the fact that intervention is needed. There is, like for instance in CMC Vellore, they've traditionally had a system where they intervene into almost every stenosis. They seem to have good results from that, but that's not something that everybody would subscribe to. Most centers don't treat like that. So it could be where you are positioned to decide what you want to do. It has to be a combined decision between you, the interventionist, as well as the patient.
And how do you manage the biologics and the anti-inflammatory drugs during the...
You should be. I think there is a lot of data now. Most rheumatic diseases, even if the patient goes for surgery, we are not really going to be cutting down on the immunosuppression much. There is a lot of data. In fact, for Takayasu, if your patient's on biological, I'd give it before the surgery, then wait for them to recover and then give the next dose. But I would be continuing most of their systemic immunosuppression.
So even during the perioperative period?
Yes, yes.
Thank you.
Actually, we've had a case, this was a time when we had no adult rheumatologists in the hospital. And I was very, very uncomfortable, but I used to get referrals from various people. So there was this young college lecturer who came in with chest pain, found to have an MI, and she happened to be employer of my cousin. And my cousin called me up to say, can you find out about this person? She's my cousin was a principal of an engineering college, and this is one of our lecturers. So I went up and checked, and I realized that what she's got is Takayasu disease, and probably the cardiologists were looking at it as an MI and not as a Takayasu. So I spoke to them and said, this is actually a Takayasu, and you need to actually start steroids and other things for her as well. I was very uncomfortable. She was 22, 23 years old at that stage, and I was really uncomfortable about, I don't like going out of my age range, but I had to convince them about that just doing, she obviously needed a stent, there's no doubt about that, but just doing the stent alone wouldn't make much difference. So there's a lot of talking to be done, and you have to already have that relationship established for these dialogues to be effective. I was hoping there'll be a lot more questions on IgA vasculitis and KD, actually.
No, I have actually a couple of questions regarding Kawasaki disease. I think it's mostly managed by the pediatricians, but most other diseases we always refer to the rheumatologist. So Kawasaki disease, we saw that, as pediatricians, we generally treat with IV immunoglobulin and high-dose aspirin in most patients. But in your presentation, we saw when you have certain risk factors, like when the patient is an infant, or when the patient is a male person, or when you present with a complication like Kawasaki shock, you need to treat with not with aspirin, but with steroids combined with IV immunoglobulin. So would you recommend giving just steroids plus IVIG, or IVIG, steroids plus high-dose aspirin? That's the first question. And the second one is, what is your recommendation for repeating IV immunoglobulin for treatment-resistant Kawasaki?
Yeah, very good questions. See, the point is, the high-dose aspirin is bystander here. It really does nothing other than work as an antipyretic. There has been absolutely nothing to show that it modifies the disease in any way, or can modify the outcome of the disease in any way. You're completely free to dispense with it, okay? And in where I would treat these patients who I think are high risk, I would give them steroids and IVIG up front with low-dose aspirin. Low-dose aspirin is extremely important because that is vascular protective. That has to be used, okay? But I don't want to use high-dose aspirin and steroids, because why do you want to give two drugs that can cause gastritis to the child and make them more uncomfortable? So I would not use that. And many of us pediatric rheumatologists, in India at least, have moved on to doing things this way. And so I think aspirin just became a habit in KD, and a habit that has stuck, but we need to kind of move away from it. We know that it doesn't really do much at high dose level. Regarding steroids, you don't need to pulse all these patients. So the patient who doesn't have shock and who's not that sick, You don't need to give them high dose IV methyl-pred. You can give them 2 milligram per kilo per day in divided doses because that acts better for the first thing. And though the Japanese recommend giving that 2 milligram per kilo per day IV for the first few days, that's up to you. I also use it orally in these patients, and that works much better. Especially with infants, I have very low threshold to add infliximab also to this mix. And we've had patients with KD and macrophage activation, which was not improving, and I've used a short course of anakinra, which has been extremely useful. So it's all depends on understanding, and my recommendation would be, I understand that it's pediatricians are the ones who are going to be seeing KD most of all, and it's really important that you diagnose early, continue managing them. But I honestly feel that there is a lot of reliance on pediatric cardiologists to help you with management, and that focus has to shift. I think if you want guidance on managing the acute anti-inflammatory therapy, it should be the pediatric rheumatologist, because cardiologists are not really versed with anti-inflammatory management or immunosuppression. It's not their skill. And so it's not something that, that's a attitudinal shift that needs to happen. Your second question about, I know that it's there in all the protocols. Where do these protocols come from? Most of these protocols come from the US and places where what is the incidence of Kawasaki in those places? You compare to nations where Kawasaki is very high. Japan. You look at the literature that comes from Japan. They hardly use second dose IVIG in Japan. You can use it. I'm not saying it's, but I logically I cannot understand what a second dose given 48 hours after a good first dose, what additional improvement is it going to have? Historically, they didn't have any other understanding earlier, so they desperately gave a second dose. That is what was happening previously. Today, my first go-to in a patient who was not improving once I've given them the initial therapy would be to go for an infliximab, or consider, if the coronaries are increasing, consider cyclosporin or maybe anakinra. That would be my go-to for these patients. Because as I said, my target when I'm treating Kawasaki, I want to prevent giant aneurysms. You may not see, IVIG has reduced the risk of aneurysms from 25% to 5%. There's still less than 5% risk is there, right? So if you want to, and that's not in all patients, the high risk patients, the infants, we are talking 50% risk of aneurysms. And small and moderate aneurysms, usually you treat them well, will resolve soon. That's not the major headache, but these giant aneurysms are a major headache. They got such terrible sequelae in the future. And you see that little toddler running around everywhere with those little time bombs in their heart, and it's very, it's very heartrending to see that, actually. So the parents understand, and the only reason you can make parents continue giving that enoxaparin injection twice a day is because they understand that it is really important. This kid could suddenly drop dead if they didn't do that. So that is the reason for this. And there are patients who need it for a few years before their coronaries can potentially resolve down to a level where they don't need systemic anticoagulation. Yes.
Thank you.
Thank you. Thank you. Yes.
Thank you so much. Outstanding presentation as usual. But I think one or maybe two important practical points: the using of low dose of aspirin in Kawasaki patient. When would you use it, and when would you stop it? I think this is very important. I'm not sure if you addressed this in your talk. Maybe I missed it. The other thing regarding HSB, sometimes those patients present with severe skin manifestation and severe abdominal pain. In our practice, we used to measure factor 13. Interestingly, it's low in those patients. And as we give them cryoprecipitate or fresh frozen plasma, they improve dramatically. So please consider it in those patients with severe skin manifestation and severe abdominal pain. If you allow me, Prof.
Yes.
Suma, for the steroid, all patients, I agree, high dose of steroid not needed anymore. Just IVIG, low dose of aspirin is more than enough in the classic straightforward cases. You will keep the low dose of aspirin till the inflammatory markers normalized. Of course, if there is aneurysmal changes or abnormal coronaries, you will leave it. As far as there is lesion, then you will decide. And important point, sometimes patient present after 10 days of symptoms, and still he has some disease activity or high inflammatory markers. Those patients deserve to be treated as Kawasaki with
Definitely.
IVIG. So you don't limit yourself to 10 days of disease.
Oh, that's definitely true, because the natural history of the disease is that the fever can subside by 3 weeks, but the inflammation may not subside by 3 weeks. So it's the optimal effect of IVIG happens if you give it before 10 days. But if a patient comes after 10 days, doesn't mean they don't need it. You definitely have to give it. You definitely have to treat them. And Dr. Suleiman is right. Previously, people were using 100 milligram per kilo per day of high-dose aspirin. It's come down to 30 now in many places. And you would only use high-dose aspirin for maybe up to 24 hours after the child is afebrile. After that, you would move down to low-dose aspirin, which is antiplatelet dose, 3 to 5 milligram per kilo per day. And that you would be guided by your echoes, serial echoes, to decide when you're going to stop it. So that is the thing. And whether about adding aspirin to the steroids, it's personal practice, I guess. I personally don't want to give a second drug that can cause gastritis, and which I don't think is doing. When you're giving a non-steroidal, when you're giving a steroidal anti-inflammatory agent, why do you want to also give a non-steroidal, which doesn't make sense to me, so I don't do it. Yeah. But that's very, very valid points from Prof. Suleiman. Yeah. So even a late presentation of KD without fever should be treated. If there are coronary features, there is inflammation going on, even that should be treated. Yes.
So once again, thank you very much, Professor Suma, for your explanations and insightful thoughts. So let's express our gratitude with the usual way, with a round of applause. Thank you. I think our next item is the quiz. So we invite you to stay inside for the quiz as well. Thanks.
It's a fun. So we talk about pediatric rheumatology over the last 2 days. So I try to recap these talks with some questions. What I will do, I'll show you some slides with the questions. Feel free to answer it, and I hope you will enjoy it. So, okay.
We thought we'd just make it fun. We have right side versus left side.
So, but the left side more.
Numbers are not balanced, but doesn't matter. The prize is a packet of chocolates. So when Professor Suleiman flashes a slide, just raise your hand. He will point to you. If your answer is correct, you get 1 point for your side of the room. Okay, if it's wrong, the other side gets to answer.
Okay. So let me start with this. I try to select cases properly or questions probably not covered by what we talk about, and some
You're
already
going to mark,
covered.
please?
So this is a 10-day-old boy
You want to sit up there?
has been referred to your hospital with symptoms of poor sucking, deep skin lesions, and bradycardia. He was born via C-section at 36 weeks of gestation due to fetal distress. Which of the following information would be of particular interest to you? Wow, okay. C, okay. So why not family history of metabolic disease. It seems he has poor sucking, not tolerating feeds. So you are interested mainly in maternal history of recurrent miscarriages and thrombosis. What do you think? What was the case? Neonatal lupus, okay. Now the second question, which of the following tests is appropriate for this boy? Serum immunoglobulin level, antiphospholipid antibody. Remember, this mother has maternal history of miscarriages. Cardiac enzyme, extractable nuclear antigen antibodies. D. So this side is answering more.
2 points for the right side. Okay.
So D. Which one of the extranuclear antigen? Anti-Rho, exactly. So this is extra question. Neonatal lupus is an autoimmune disease acquired during fetal life as a result of transplantal passages of maternal antibodies. What are the responsible antibodies? Already answered. Anti-Rho, true. Alone or other antibodies? Sorry? Anti-La, anti-Rho, anti-La, okay. What else? Probably people are not aware about RNP. Also, this is another antibodies responsible about neonatal lupus. So please consider it in your request. You need to ask about anti-Rho, anti-La, and anti-RNP as well, okay? Now, what is the frequency of congenital heart block in newborns of anti-Rho, anti-La positive women with known connective tissue disease?
Someone on the left.
Okay. 2. So I'm asking about frequency number. So it's almost, you are right, 2%. She answered
Whoa,
correctly.
1 point
okay?
for the left.
And the risk of recurrence is almost 10 times, means almost 20%. If mother had neonatal lupus baby, the next pregnancy will be almost 20%. Now, what is the risk for developing offered connective tissue disease in this mother of infant with neonatal lupus? Now, it's opposite. Baby has neonatal lupus, and what is the risk of developing offered connective tissue disease? Is it high, low? So the answer is highly debated, with estimate ranging from 2 to 70%. So it's wide range. So it's difficult to answer this question. Now, this is a common question we have been asked from the parents. Can neonatal lupus turn into lupus? What do you think? If we remember the pathogenesis, probably the answer is no, because the affected infant or child does not have SLE. Neonatal lupus is different entity and separate disorder, because the disease will disappear as this maternal antibody wash out from the baby blood. Now, let's go to a second question. A 4-year-old girl, remember this morning talk, referred due to recurrent episodes of fever and non-itchy raised rash. She has recently developed eye and joint symptoms along with the diagnosis of sensorineural hearing loss. The most appropriate diagnosis is FMF, systemic GIA, chronic urticaria, Mickle-Wool syndrome.
Right
Say.
side wants to guess D.
D. What do you think this side? FMF, most common. So why did you choose D? You are right, D is the correct answer, but why?
Wow.
Yeah, because the patient has deafness, urticaria rash, and this is again a clue for the Mickle-Wool syndrome rather than FMF. Okay. 4-year-old boy presented with these findings for the last 6 months. This is from Liz's talk yesterday. For the last 6 months, what do you call these findings? C, B? We heard C and B. What is the answer? B, dactylitis. Yes, absolutely. This
Oh
is
no,
dactylitis.
right side, you're in the lead. 4 points
This
versus
dactylitis.
1.
Okay. Now, after learning the mother has untreated chronic skin disease and the father has Crohn's disease under treatment, which is the diagnosis or most appropriate diagnosis? Is it reactive arthritis, psoriatic, sarcoidosis, oligo-GIA? B. Why did you choose B? No, we don't mention anything about HLA. But because the mother has chronic skin lesions and this child has dactylitis, most likely this is psoriatic arthritis. You are right. Okay? Less likely to be reactive arthritis, less likely to be sarcoidosis with this strong family history. And again, if you see dactylitis, it's not oligo-GIA. So GIA usually affecting the large joint rather than small joint.
Which side gets the point?
Well, I think she answered it.
Right side. Come on, left side, you can do it.
I'm a little biased because I'm focused on this side. Okay, this is from Prof. Suma talk.
Raise hand.
An ophthalmologist called you about 10-year-old boy with these findings. He has recurrent headache and poor vision over the past 6 months. His workup showed leukopenia, high ESR, sagittal sinus thrombosis. 4 weeks later, he developed abdominal pain, hepatomegaly, and elevated liver enzyme. What is the most likely cause of this finding? What do you think the diagnosis, to start with? No, what do you think the diagnosis before? What is the diagnosis? Patient. Okay, I think they are right. So
Okay,
what's
1
the
point
answer?
for them.
What is the answer? C, okay. It's difficult to judge.
Okay, 1 point for both, but
Both.
one extra point for the left for beige heads.
Now, again, this is from Prof. Suma talk. 6-year-old boy presented with a 12-day history of persistent fever and joint pain. He was treated with antibiotic showing partial improvement. Lab result indicated leukocytosis, thrombocytosis, high inflammatory markers, hypoalbuminemia. The most appropriate differential diagnosis is B? D, okay. I heard B.
He awarded it to the left side.
Okay. We have another question. The treatment of choice is high dose of IV methylbrate, low dose of Astal or aspirin, multiple doses of IVIG, high dose of
Okay,
aspirin and
this
high
side,
dose.
raise the hand first.
What is the answer?
The right side, raise their hand first so they can answer first.
Why did you choose B? C? C, okay. Okay. The answer is C. At least among these, you may consider it, although we just mentioned we don't need high dose of aspirin. Now, it's a bit tricky. Maybe if we modify it, low dose of aspirin with high dose of IVIG will be the best, but among these choices, you will choose C. Okay?
Okay.
Okay, which of the following is considered risk factors for developing of uveitis in patients with juvenile arthritis? Systemic GIA, positive RF.
A hand over
GIA.
here.
C.
Okay. Come on, left
I think
hand.
they are good all. Okay. Yeah, the answer is C. You are right. 10-year-old boy with 6-week history of monoarthritis underwent arthrocentesis, which synovial fluid analysis result is consistent with GIA.
Delini. She said B.
Yeah.
Wow,
She's
okay.
right. Yeah. But she said first.
Yes, currently the score is 9 and 4. Come on.
Okay, 7-year-old boy with history of periodic febrile attacks and peritonitis-like symptoms occurring monthly since age of 3. What genetic test result is most relevant?
Hands. Oh, on the right-hand side.
Yes, she is right. Yeah. Yeah, the Smith gene, most likely this is FMF. Great. So not 2 with Blau syndrome. It's not with the FMF. And WISP3, this is with the pseudo-rheumatoid dysplasia and LAC1 mutation with arthropathy or familial arthropathy. Okay, 10-year-old boy presented with these painful lesions, myalgia, hypertension. Lab results showed leukocytosis, thrombocytosis, elevated inflammatory markers. What is the most likely diagnosis?
Someone on the left. Someone on the left raised their hand. What's your answer?
C? Yeah, I think she is right. B.
Try again.
The answer is here.
Okay, got it.
Yeah, remember this
I'm here to
patient
make sure I
present
can
with
see your hand.
with erythema nodosum, high inflammatory markers, myalgia. This is not present with HSP. I'm right, Soma? Do you agree? Okay. Now, 5-year-old boy recently diagnosed with polyarticular JIA and started on methotrexate adalimumab, needs guidance on immunization. What is the appropriate recommendation? All immunization should be paused until he stopped the current medication.
The hand there.
D. Let me read it and see. Flu vaccine is contraindicated. Live attenuated vaccines are highly recommended. Non-live vaccines are highly recommended.
They get the point?
No, wait. We don't finalize it. So what is the appropriate recommendation? Would you tell her, please keep on hold all vaccines, or flu vaccine is contraindicated, or live attenuated vaccine are highly recommended, or non-live vaccines are highly recommended? A. So you will ask her to postpone all vaccines? No. She should take the appropriate vaccine. Live flu vaccine is contraindicated? No. We recommend to give live flu vaccine. Live attenuated vaccines are highly recommended? No. Live attenuated shouldn't be given while patient is taking immunosuppressive medication, especially biologics. So non-live vaccine are highly recommended. Okay, clear? I think here.
So you're correct. Yay.
A 10-month-old girl recently diagnosed with post-GIA needs eye examination. What is the recommended frequency? Annually, every 6 months for 7 years, then annually every 3-4 months for 7 years, then annually. If the initial exam is normal, no further assessment is needed.
The hand here. The hand's here.
Yeah, okay, what's the answer? C? Yeah, I think they are right. C.
Okay, yay,
Yeah.
left side.
So this girl, she is girl preschool age, and she has post-GIA, so she's high risk group. So they need every 3-4 months for 7 years, then annual exam, providing no uveitis. Otherwise, they will tailor it according to the eye disease activity. Okay, I think this is very simple. 10-year-old boy presented with antalgic gait. The work-up revealed this finding. I hope it's clear from here. Which of the following is considered a risk factor for this condition? What is the diagnosis here? What is the diagnosis first? Sorry? Slip capital epiphysis, okay. So the answer is A? Yeah, you are right.
Both
Both
sides?
sides?
Okay.
Okay, 7-year-old girl was referred to your hospital due to 6-month history of limb. You have to sit here. Better for otherwise you will break your back. Due. Okay.
Sumara is trying to be fair. Okay, we'll really go by hands. Okay, I'll help you
Okay.
see which hand goes first.
7-year-old girl was referred to your hospital due to 6-month history of limping. Upon examination, these findings was noted. Which of the following lab tests would be most relevant?
I see a hand on this right side.
Okay. B. B. So both.
B.
Yeah.
Correct.
Both of them correct.
Prof. Suleiman is very fair. He's trying to give you both points. Okay.
You have
so
been. Okay.
7 points on the left, 14 on the right.
You have been requested to evaluate this boy as a new consultation. There is no history of trauma or burns. A review of system was unremarkable. Examination showed the limited range of motion in both ankle and subtalar joint. Which of the following statement is most appropriate? So what do you think the diagnosis here? From yesterday's presentation. Yeah, this is localized scleroderma. True. So what's the answer here? Familial cases are very common. It is reversible with favorable outcome. Usually the inflammatory markers are very high. It is the most common subtype of this condition in children.
I think the gentleman on the right, he raised his hand first.
Who? D. I think he's right. Yeah.
Okay.
So familial cases not usual, and unfortunate. Even with good treatment, if there is a damage, it is there. It will not reverse it, and usually the inflammatory markers are normal, so we don't depend on it. Okay, 18-month-old girl with polyarthritis, recurrent fever, and an ill appearance is found to have pancytopenia with hyperferritinemia and was recently diagnosed with systemic GIA. Which is the key pro-inflammatory factor in this case?
I see you on the left.
So what's the answer? A? Do you agree? The right side? So we'll consider the answer.
1 point for the left.
Yeah, you are right. Aisle 1. The most common cause of mortality in childhood lupus is rapid progressive glomerulonephritis, Liebman-Sack endocarditis infection, and interstitial pneumonitis.
The right side was faster.
Who? Here?
Right side.
What's the answer? C, infection. Absolutely. So in a patient with FMF, what is the most common gene detected associated with severe disease and higher risk of amyloidosis? I mentioned this morning.
Who's guessing? Oh, I see on the right side.
So any answer, let us give a chance for A. Okay, A.
Who got the
A.
point? Right, left?
He answered A, which is correct.
Okay, left side.
A 4-year-old girl experienced recurrent night pain in her calves and thighs that improves with massage, with no daytime pain or limping. Physical exam revealed no arthritis, muscle weakness, or tenderness. The most appropriate answer is?
Those at the back on the right were the fastest.
A. The most likely diagnosis is growing pain. Yes.
Okay.
Which of the following condition associated with low serum complement C3 levels? Sarcoidosis, acute serum sickness, familial Mediterranean fever, granulomatous with polyangiitis.
There's a hand on the left side at the top, the lady.
Okay.
B.
I hear D or B?
She says B.
B. Yeah, the correct answer is B. So I don't know if you hear it B or D, but the correct is.
Yay.
Okay, this girl was referred to you due to history of hemolysis, hypertension with potential immune response mechanism. What potential immune response mechanism could be involved in her condition?
The right side at the back.
Yeah, he said it clearly. A.
I
Yeah.
think they were the fastest. Oh no, okay. For this one, my fault. I was not looking, so I'm gonna give you both, okay?
Anyway, the answer is A, and you decide, okay? Okay, a 7-year-old boy presented with a history of arthritis. Examination revealed these findings and murmurs consistent with mitral regurg. Which of the following tests would confirm your diagnosis? Very
They're
simple.
definitely the fastest. Okay, right side. See, come on, left side. I'm rooting for you.
Upon confirmation the diagnosis, which of the following statement is appropriate? Treatment with high dose of steroid, extended course of oral antibiotics, either aspirin or another NSAID drug will be enough. Secondary, D, okay.
D?
Yeah.
Both sides. Is it true, both sides?
Okay. If you remember what I said this morning, this child has known to have periodic febrile attacks associated with peritonitis-like picture. He has recently proved to have homozygous MEF gene. He presented to emergency room with these findings. Tender. The answer is, yeah, they are good. Yeah,
Wait. Okay. Okay, I'm going to look for the hands. Just because you shout first doesn't mean the point is yours, okay? Right now the score is left side 12, right side 21. Prof. Sulaiman has still questions, so don't give up.
So the answer is A, erysipelas. Yes, absolutely. So a 12-year-old girl first noticed her condition at 18 months. She has progressive joint, this is from Prof. Sumaira talk yesterday. She has progressive joint swelling, especially in a small and large joint, and difficulty sitting with crossed leg. Which of the following variants has a causative role? This child has, I will give you a hint, this child has CAC syndrome. Camptodactyly arthropathy coxsafara. You can see the coxsafara clearly and the camptodactyly here. So what is the responsible gene?
On the right.
D. No, D, this is for hyper IgD syndrome. So it's out. A, no, this is the thing. So you will give me the point.
1 point for Prof.
So
Sulaiman.
the answer is C. C. PRG4. I know this is very rare, but we have many cases. We describe this syndrome, by the way, CAC syndrome, we describe it. So we reached the end almost. This patient was referred to your clinic because of a new onset of severe back pain. He was on long-term treatment for chronic arthritis. Which of the following this is appropriate? So what do you think this lesions? Stria, exactly.
The right side.
Uh-huh. B. C. Say it again. D. Okay, let us vote. Nerve conduction study? No. Okay. Bone mineral density? MRI with gadolinium? Thoracolumbar spine X-ray. I think deserve it, clearly.
They guess B
D.
and they guess C as their first
No, they
answer.
said D. D, yes. He says D.
Oh,
yeah,
okay.
You need, of course, you need, in this situation, you need to do just plain thoracolumbar, just to see if there is any fracture. So then you will proceed for bone density, whatever. So the first test, you need to do it, thoracolumbar X-ray.
Okay, then they'll get the point.
Which of the following is the commonest cause of toe walking in preschool children?
Definitely.
Duchenne, congenital, shortening Achilles tendons, habitual autism.
The right side at the back.
C. The answer is right.
All right. 1 point for the right. Come on, left
Okay,
side.
this is again from Prof. Suma talk. This is a 6-year-old girl who presented with colicky abdominal pain associated with bloody stool. Which of the following statement is true?
I think the man at the back on the right raised his hand first. He said B. They said B and A, and they say C.
So no, we need to hear one answer from one side. A.
A on the right. The left? C.
So the answer is A. Okay, because this reason it's mandatory to confirm the diagnosis, because chronic arthritis is well known associated. No, usually they don't have chronic arthritis, it's transient or acute. Associated GI manifestation usually 2 to 3 weeks, not months. And most affected children will have uveitis, nothing to have to do with that. So the answer is A.
It's okay, good try. No negative points for wrong answer.
I think this is the last question, or maybe another one. This boy has been limping for the last 3 months. Your professional diagnosis is GIA. Which of the following items is helpful to classify the disease? Classified disease. Patient age and gender, number of affected joint associated symptoms, family history of similar condition, response to treatment.
Okay, this lady on the left.
Okay, what is the answer?
B.
You agree? Yeah, the answer is B. Exactly.
Okay.
Because this is important. The number of joint and associations, you can figure it out what is that. I think this is the last question. 9-year-old girl who presented with history of intermittent knee arthritis, recurrent swelling as shown. She was found to have thyroiditis, high ANA, anti-Rho antibody titer. Your professional diagnosis is? There is.
Left side ordered answer for the man in the stylish shirt.
What's the answer? B, D.
D or B? D. D?
Demon dog.
Yeah?
D. Yeah, the answer is D. Shock
Yay.
answer. I think I have more. Oh, okay. So this patient needs the following test.
Who got that point?
I don't know. I was looking to the screen.
Okay, I'm going to give both because you're
Okay,
now too
15-year-old
fast.
boy presented with pain at the top of the shin bone. Clear?
I think left side. Left side.
The answer is B. You can choose. Okay.
Okay.
Okay. This is a 13-year-old boy presented with pain at the top of the shin bone. It gets worse with running, jumping, and going upstairs. What is your diagnosis?
Right side. Wait, what is the right side's answer?
No, I think this is, this is a bit wrong because the slide doesn't make sense at all. No, we'll skip this question. We'll skip it.
Minus 1 point from us.
No, we'll skip it. Because the photo doesn't match with the answer, the question. This girl has recently experienced difficulty with daily activities and was found to have Gower signs.
But definitely the man there raised his hand first.
Okay, A. The answer is
They
A.
guess A.
Okay, a 6-year-old boy presented with gradual antalgic pain and was accompanied by limited painful internal.
Oh my God.
C. They are good.
Who got the point?
While
Both sides.
I think this is the most appropriate statement for this boy. Intra-articular steroid injection, That is the ideal treatment. Positive family history and low birth weight risk are risk factors. Transient sinusitis is the only differential diagnosis.
Right side, raise hands first.
So what's the answer? B?
Wait, right side, what's your answer? Huh? What's your answer, right side?
C?
Right side C, left side D. D or B? B.
Actually,
D for donkey. Okay, so right side C, left side donkey.
oh, the answer actually B. Both. Positive family history and low birth weight are risk factors. Thank you very much.
So to announce the final score, and I'll let
You should announce.
I'll ask Madam to give the prize. It was a good show. Here, I hold it. The left side, you did well. You did well, but unfortunately a little bit too late. But 18 points, not bad. Right side, 27 points. Yay! So we just get one of the representatives from the right side to get the prize from.
Divide more and less, perhaps?
Oh yeah, sure. Your madam is very fair. She says we'll just share the prize so that everyone can have a bit, okay? You can we'll just pass it up and you can just open it and take one piece.
Just before concluding, is Dr. I think Suaira online? Yes. Dr. Sumaira, can you hear us?
Yes, absolutely. Can you?
Right, we can see you now. This is Duminda here. Yes, as the convener of the APLA pediatric group, we would like you to give the concluding remarks. And while they are while we would like Professor Dr. Sumaira to give her concluding remarks before finish, and then we'll take a photograph with all of you here, and then go for lunch. Dr. Sumaira, please.
Thank you. I just want to thank all of you, both the colleges in Sri Lanka, Jayatri, for organizing such a fantastic, course. The audience was great and the speakers were outstanding. Wow. I learned so much. And I'm so sad I'm not there. But it was so much fun also. So I think, evolving amongst ourselves to have courses to our activities, and I think Sri Lanka was the best place to start. Thank you and enjoy the rest of the day. Thank you so much.
Thank you, Dr. Sumaira. Thank you very much. And on behalf of the College of Rheumatologists in Sri Lanka, I would like to thank again the APLA, especially our guest speakers who came all the way, and Dr. Sumaira, who was with us both days continuously. And of course, this is the second time we are missing her, because I can remember she was one of our guest speakers during COVID time when we had an online annual session, and we are very grateful that you always supported Sri Lankan rheumatology. And I would like to thank College of Paediatrics as well for supporting us, coming and joining us in this endeavor. So hopefully we can carry forward from here and make the rheumatology in pediatrics as well, because I think the Board of Studies in Pediatrics is now in the process of making it a subspecialty for post-MD pediatrics. So we will support you. We want that. And we'll take it up. And hopefully the rehabilitation pediatrics will also come so that geriatric can be relieved from burden, and we can sort of spread it all over the country. So please, all the registrars in pediatrics, please look forward and join us for that.
Yes.
Thank you very much, and would like to everybody come down here. We'll take one last photograph. Yes, please. Yes, please. Please be there. We want you in the photograph.
I will be there.
Please come. We will give in some time for the caterers to get ready. So that's if you go now, you will get a heart attack. Please come down, please. Shall we take? Oh no, they can go back. But Dr. Sumaira, we can't see you. No, we get some. Can we get some of chairs down and we have resource person seated? Brother Sumaira, we can't see you. I think we need you. Right. You are putting your best makeup. Come in front. Pulane, ko dabe photographer. Metra dagat pulane photo tiyal makal. Yeah, faculty. Then we have. No. Then they can sit behind, stand behind, so that we will not miss anybody. So ganno na ganno. Napti bas bol mat yan. Please.
Thank you, Sumaira.
Of course.
Yeah, thank you so much for making it possible. We really enjoyed it and learned a lot. I'm the one who learned most, I think. Thank you so much. Yeah.
Thank you.
Okay.
Bye.
Bye.
Bye. Bye.